Morning, Jack.
What are you doing here?
I'm working. And you?
Oh, I don't know. Had a guy come in, hit by a drunk driver in a crosswalk, 39-year-old vet. Survived 3 tours without a scratch. I spent the last 2 hours coding him.
That's always a rough way to end the night.
Must have had a reason at one time to keep coming back, but I can't think of it right now.
Because this is the job that keeps on giving. Nightmares, ulcers, suicidal tendencies. Besides, if you jump on my shift, that's just rude, man.
Hope I'm never one of your patients.
That makes 2 of us, my friend.
I got a pregnant teen coming back today for a mifepristone and a small bowel obstruction waiting on surgery for the last 3 hours. Oh, and unfortunately, the Kraken is still boarding at VA.
Still? Guy's been here for a week waiting on a psych bed.
Yep, he's only getting worse. He's catching some Zyprex disease at the moment, but when he wakes up, God help you all. I wrote a note for the family of my dead vet if anyone shows. Oh, and you got the med students and new interns starting today, so good luck with that.
Lucky me.
Sir, come back here.
No more needles!
Oh,
Sir!
No more needles!
Stop!
sure you want to work today, huh?
They're gonna hurt me!
Dr. Rabinovich? Melissa King. I will be joining you today. I just came from 2 months in the VA.
Hey, welcome to Pitt. This is Dr. Jack Abbott.
Nice to meet you. I can't tell you how excited I am to be here today, so.
Talk to me at the end of the day.
Ignore him. He had a rough night. And is having an ongoing existential crisis.
Don't worry, you'll get there soon enough.
I'm married.
And meet back here for a full briefing in 5 minutes, brother. I'm so fucking glad to see you.
Heard it on the police scanner. How many we expecting?
I don't know, but it doesn't sound good.
Where do we put the disaster bin?
Behavioral health, that's now our central supply.
And get
Let's go.
extra security. We have to do the waiting room and find out.
We got more bins coming.
Thank you.
Right side, left side. I'm gonna need you to grab folding tables from facilities to organize all this stuff.
Copy that.
Go, thank you.
Anything in the Abbot bay, just get him moved out of there now.
I'm taking primary ER.
Have at it.
Who's taking primary surgery?
Heavy as the head that wears the crown.
Dr. Walsh. Anesthesiology.
That will be down. He's got 4 in place, more on the way.
Okay, this is yours.
Thank you. What you got in there?
A couple of cat tourniquets, hemostatic dressings, LMAs.
Oh, yeah, that's good.
Butterfly ultrasound works off a cell phone.
Ooh, that's cool.
Yeah.
We're gonna send all the unstable chest and belly straight up to the OR. Okay, everybody, listen up. This is how it's going to work. Our ambulance bay is now our triage. EMS will be overwhelmed. Most will probably arrive by car, several victims per vehicle. For all you newbies that don't know, Dr. Shen is our night shift attending. John, I'm gonna put you on point triage.
Cool.
Triage will decide who goes where depending on their injury.
Every department will have a designated primary who will oversee their staff. If you need someone, look for the vest. We're all gonna have walkies. We can get you whatever you need.
No patient goes into a room unless it's a trauma bay, and they will have 4 patients each. We need to keep everybody out in the open so we can keep an eye on everything, okay? Triage is gonna assess and assign every patient to a specific zone with the colored slap band. Patient who comes in with a red slap band goes to the red zone, which is the trauma rooms with overflow out here. These are the most critical patients who will die without immediate attention. Samira, where are you? You are here. With Dr. Abbott and me, Jack's gonna run traffic.
We have 5 minutes to try and stabilize the reds. After that, it's OR, ICU, or morgue.
The south and central common area over there will be the pink zone. That is for patients who will die in under an hour without treatment. McKay and Javadi, you were over there with help from incoming night shift and surgical staff. Yellow zone is the north corridor. Those are gonna be mostly extremity wounds. Good vitals, talking. Mel, you're gonna run point there with Santos and Whitaker.
What if there's a pulseless extremity?
Oh, if you can't feel a pulse, check for Doppler flow with this. It's a mini ultrasound. Follow the screen prompts.
But a yellow can change to a red if they go south. You gotta stay on top of them, even if they seem stable.
Okay, yeah.
You got this, Dr. King. Green, minor laxant sprains, they go to family medicine. Black and white bands are DOA, imminent death. Peds is now our morgue. Let's hope we don't get too many of these.
We're a MASH unit now. There's no charting, no electronic medical records, no board.
How do we document treatment?
Oh, you'll all get Sharpies, and every patient has a wrist chart to document treatment and procedures. You run out of room, right on the patient's forehead.
Really?
Yeah, really.
Each wrist chart has a unique mass casualty incident, barcode, and patient number. That's how the patients are gonna get identified.
This is no frills combat zone medicine. No ultrasound, no x-rays, no CT, no labs. Assessed based on mental status and pulse strength. Every critical patient gets an IO, intubation, a unit of blood, and chest tube if needed. Everything you need, blood, drugs, bandages, everything will be in the behavioral health rooms. That's our supply depot. Keep a couple of 11 blades in your pocket. Goal is to resuscitate ASAP, so they'll make it upstairs for definitive care.
Trauma surgery and neurosurgery will decide who goes up to the OR immediately and who goes to the ICU for further treatment and evaluation. Communicate. Ask for help if you need it. Trust your attendings. We will get through this together.
Damn right we will.
I'm gonna see who needs help.
IO's in, go with OPAs. When there's no time, bone marrow infusion's as good as an IV. Robbie, stabilize for the flip. Go.
He's got a wound on both sides. He's gonna need 2 chest tubes.
Yeah.
Need a hand?
Hell no, I got 2 hands. Didn't make it. Going to Peds.
Another red and trauma 1.
Copy that.
Give me a 6.5 and a bougie.
I got the bleeder. Foley catheter with a 30 cc balloon.
Are you donating?
Oh, neg. Yeah. You doing a Craig?
Yep. No skin hooks, no bougie, old school.
Got a tactical airway in my bag here.
What is that?
It's a control Crike kit.
Oh, that's perfect. Use that on the battlefield.
Works in the pitch dark when you're under fire. I can do these with my eyes closed. You. Okay. Knife leaves a trach hook behind, so you can't miss, right? Just good. Slide in the introducer. Okay. Feel the tracheal rings, good. Bob's your uncle.
That was incredibly fast.
Yeah.
Balloon is up.
Why don't we stop these?
No room in the budget.
Yellow and entitled.
It's okay now.
Yeah.
Thank you, Dr. Abbott. Okay, let's pack the oral cavity with Krillix and see how fast head and neck can take him up to the OR. Great job, everybody.
What else do you got in your go bag?
Oh, just wait and see.
I'm at 15 centimeters with 5 cc's of saline so far.
Raboa, are you shitting me?
I told her to stop.
Uncontrollable bleeding from a pelvic artery, no other options.
We need an art line to know if the BP is up.
We'll go with pulse strength and mentation.
Carotid's weak, radial's barely there.
Another 3 cc's in the balloon?
Injecting?
I'll try for palpable systolic.
Yes, go for it.
Whoa, radial's much stronger now.
Okay, lock the balloon, check the wound. Go.
BP's 110 by palp.
That'll do.
Yeah, wound's dry, barely a trickle.
That's because there's no blood going to her legs.
Okay, the clock is ticking. Balloon can stay up for 1 hour tops. Get IR and vascular on the case.
Hey, hang in there, Carmen. Hey, you're good, okay?
Okay, you never should have done that on your own, ever. Do you understand? But that was pretty badass. You saved her life. Good job. Robbie, get some air, brother. Check on triage.
Dr. Abbott, I got your carotid bypass guy up to the OR. Vascular surgery says to give you mad props.
Okay.
A shot, strapped a t-shirt and a belt around his thigh and ran around helping people for a few hours.
Holy shit. Check out the 4-chamber apical view.
Dilated right atrium and right ventricle. Right-sided strain with bowing of the septum.
Sounds like a PE. You throw a clot from having the tourniquet on?
Way too soon for a DVT. Okay, let's get him in left lateral decubitus. 1, 2. Van Dellenberg, ASAP.
What for?
Intracardiac air embolism, all that running around introduced air into the femoral vein right up to the heart. Now it's blocking blood flow to the lungs.
Need a CT to confirm.
They're still backed up with other patients.
Well, maybe the cath lab can take them. They have fluoro. I'll go check.
Yeah, good luck with that. I need a central line kit and a 5 French pigtail catheter.
I got it.
He doesn't have a collapsed lung.
Yeah?
So what are you gonna do?
I'm not gonna do anything. You are.
Got the IJ.
Okay, back to business as usual, thank God. Guide wire and introducer.
What the hell are you doing?
Dr. Mohan is about to pull air from the right atrium and right ventricle.
With what?
5 French pigtail catheter.
Inside his heart.
Multiple side holes gives you a better shot at sucking out all the air.
Dr. Abbott showed me a case report from South Korea.
What the actual fuck? I just talked to cardiology. They want a CT scan. If it's showing air, then you need to dive him in the hyperbaric chamber.
He'll be dead by then.
Not if you kill him first with this banana pants
We don't
procedure.
have time to wait for your fancy pants machine. We don't get the air out of his heart, he'll die.
This is not the standard of care.
Fuck standard of care. If we want to save him, we go in now.
Maybe I should.
Right in the pigtail. Excellent idea, Dr. Mohan. Go down to the 24 centimeters, and then we'll confirm with X-ray. Good.
Think I'll stick around in case you need another set of hands to resuscitate your patient when he crashes.
Pigtail's in the right atrium. Good position. Aspirate. See what you get.
Pulling back blood from the heart. Along with some air.
How about that?
BP's still only 85 systolic.
No improvement.
Advance slowly into the right ventricle.
How do I know when I'm...
PVC.
That's how you know. Aspirate again.
Run a 3,
More blood and air coming out.
run a 5.
Non-sustained BTAC. Charge to 200 for when he deteriorates.
May need blood now.
Pull the pigtail back to the RA.
Step aside.
Pull the pigtail, Dr. Mohan.
Step aside.
You got this.
Normal sinus rhythm, 92. Pulse ox is improving. BP's 112/84.
Not too shabby, huh, Dr. Walsh? I think we can admit him to general surgery now.
Hell no.
He's a gunshot victim.
Admit him to the cardiac ICU. We'll consult from there.
Or you can admit him yourself with cardiology consulting. I thought you liked flying the plane.
Not when it's gonna crash.
Solid work.
That was your save, not mine.
Take the win, Dr. Mohan.
Thanks.
Besides, it was a little too risky for me to do myself.
What?
Suture.
Yeah.
Hey, you got a second?
Yeah.
What is up with Robbie?
It's been better. I'm really worried about him. Never seen him like this, have you?
No. How about you, Slugger?
Been better.
Preach.
Sorry to interrupt.
Oh, if you guys are looking for Officer Stefano, he went up to surgery about an hour ago.
We're looking for Dr. Cassie McKay.
Yeah, that's me.
We were alerted about your ankle monitor being tampered with. Had in probation called to check in earlier, but you never responded.
Yeah. It was beeping and giving an error message, and we were in the middle of a mass casualty. Pitt Fest.
Did you tamper
And
with your ankle
some-
monitor?
Yeah, I might have drilled a hole in it.
Officers, look around. She's saving
know.
lives.
Put your hands behind your head.
Whoa, whoa, whoa. Hang on a second.
You gotta be kidding.
Officer, wait
You're
a
under
second.
arrest.